Every patient, unfortunately, has this very sad story where, this is a 62-year-old lady with a set of implants from 1989. So she uh, was not sure if this was silicone or saline and above or below, and that she just knew that she had the implants. And now she comes to me with what is a grade 4 contracture on the left side. And this was done in the end block fashion on the left. And as you will see, capsular contracture, grade 4, means that the breast was indeed what was deformed and hardened, and that she had palpable and visible implant. And there it was painful. Painful is what is the difference between grade 4 and grade 3, where the implant is hardened, palpable, and invisible. So the because it's very hard, and we're going to cut that second. So the grade 1 capsular contracture is when the breast is soft and the implant is not palpable and not visible. So it's like kind of normal, if you will. Uh, Grade 2 is where the breast is solid and the implant is palpable but not visible. And again, grade 3, like we talked about, is like grade 4 minus the pain. So grade 4 is pain. By definition, becomes a capsular contracture that might be impinging on a nerve or other nerves that feed the nipple. Now, as you will see, I cut out the excess skin. These are implants from 89. So these are 35-year-old set of implants. I cut out this tissue to help with the aesthetics. Now, as I was dissecting, you can see it's very thin capsule. And as I was dissecting, remember over here, if I touch this, you can see how paper thin this is. Now, during the process of dissecting, I actually went into the capsule. And so what I did was I put a stitch in it, as you can see right here, to lock it so that the internal content. So this is like another trick. If it does happen, inevitably it does happen, then you can always close that hole and continue to dissect. And this is what is a 100% total capsulectomy, and plus the inflamed tissue that's around. So all of this tissue was removed. Now let's go ahead and you can see how flattened and kind of soft and it will conform to this flat surface, whereas this one is so hard and like a ball, like literally a softball. So I'm going to go ahead and cut this open, and as you will see, she has what is a implant, just like we saw yesterday. This is your fluid around. So if I go take this fluid, it's a little bit on the yellow side, older, obviously, as you can imagine, an intact implant. So interesting, 35 years old. And you can see all of this fluid. Even if I hold it in my hand, you can see all of this fluid. And especially if I go like this, look at this. This is your gel bleed that's slowly leaching into the periphery over the years, right? And the capsular tissue is somewhat holding it. And this leaching discharge goes into the periphery. And so you can see, look, how so paper thin this is. And yesterday was the very similar case, and you can see how I can see read the numbers www number 2, for example. Over here you can see how transparent thin the capsule can be right here. There was number 12, number 4 here. So the bottom line here is that no matter what, all of this inflamed tissue, now as you can imagine, the capsule is so thin that you don't appreciate much of the capsule. It's more the fatty tissue. So all of the tissue has ended the fatness. You can see, look at this. Sometimes we have heard some surgeons say, the capsule was so thin I left it behind. No, it's this tissue on the side and the periphery where this leaching has gone into that needs to be removed. And so overall, I'm very happy. Some areas relatively thickened over here. And again, the pathologist will weigh in, all done. And as you can see, it doesn't take much. So if I go like this, it doesn't take much to tear into the capsule. If it does, you can put a stitch, or I used the gauze before in the past. I'm going to go ahead and change my gloves. So, new pair of scissors. Now look at how hard this is. Very hard tissue, like rock hard solid. This is done in the end block fashion on the left side. And as I cut this open, The question is this ruptured or not? Now, statistically, a very high chance that this is ruptured. Uh, and we will see what it shows as I cut open. Again, the goal here is to always assume all implants are ruptured till proven otherwise. So it's very, very tricky here. Remember, it is tightly adherent to that capsular wall. Let me go in from here. Very, very, it's like slippery. So partially in. Let's see over here. Remember, this tissue is the capsule, but this tissue is very inflamed as well. It has to be removed. So I'm going to go in from here. Let me find another access point. All of this tissue is inflamed. Here we go. Let's slide the other softer part in. You can see how tightly squeezed this is. I'm going to go in from here. It appears intact. So you can see it literally came out, and you can see how it was compressed in. If I press in, you can see it's a intact implant, textured implant. And again, this is my new pair of gloves. If I go like this, you can see that stickiness. And this is no information on it. And let's go ahead and look on the inside. Look at these calcifications that we know of. I'm going to go ahead and snap this. You can see how razor sharp this is, as you can see. Hard calcification. Actually, if you can. So, very thick capsule. I'm actually going to go ahead and cut this. You can actually hear it being cut. Very hard calcified tissue, and how it was encasing this implant. And interestingly, over the years, it did not rupture. So all inflamed tissue has been removed. So the teaching point here is the capsular contracture grade 4, round like a ball, not ruptured right or left. Left one was done en bloc, and I'm very happy and content with how the whole dissection has gone. All inflamed tissue has been removed. In this case, it was above the muscle, both of these implants. No inflammatory burden has been left behind. I'm very happy and content with how this 62-year-old lady is done. I cut out the excess skin that really helps with this aesthetics. So implants will be returned to the patient, capsules sent to pathology, rule out the BIA-ALCL CD30 analysis, rule out lymphoma, rule out malignancy. Number 3, cultures for aerobic, anaerobic, and fungal. Number 4, high definition pictures and videos of me cutting open the live and also of the test showing complete removal of the capsule. Twilight sedation. And then the no drains, no lift, and then every patient, regardless of age, gets the same surgery so that they have complete removal of that inflamed tissue. And capsular contracture is certainly a red flag. We do not know why it happens. When the implants are above the muscle, higher chance for capsular contracture. It's been shown larger implants lead to capsular contracture, but majority of the times we do not know why. Sometimes bacterial colonization or that biofilm that forms can lead to a capsular contracture. It can occur all of a sudden from nowhere. And one side may be perfectly normal, the other side may have a grade 4 contracture causing the pain, as was this case today. So there you have it. This is Dr. Khan, Executive Plastic Surgery.